turn the meeting over to your host, Sarah Burnell. You may begin.
Thank you very much, and on behalf of the National Cancer Institute, I wish to welcome everyone to the April Advanced Topics in Implementation Science webinar. Today we are so very delighted to welcome our presenter, Dr. Abe Wandersman with the University of South Carolina. He will be joined by our own Dr. David Chambers, who will be moderating the session. A very brief word about logistics, and we'll be off. As the operator said, questions are encouraged, and there are two ways that you can ask your question at the end of the session. You can press *1 to ask your question on the phone live. You'll be placed into the queue to do so. Or you can type your question into the Q&A tab at the top of your screen and hit Ask to submit the question. You can submit the question at any time, but we'll be opening the session for questions when all the speakers have finished. Without any further ado, it is my pleasure to turn the meeting over to Dr. David Chambers.
Thanks, Sarah, and thanks so much to all of you for joining us. As some of you may know, the Advanced Topics in Implementation Science webinar has been a chance for us to try and spotlight some key areas within dissemination and implementation research that some of our in-person training and other things have not been able to delve into as much depth. In recent months, we've begun a series that has really tried to go beyond an overview of different dissemination and implementation research frameworks to try to spotlight the development and the use of common and well operationalized frameworks that have been developed by our investigators within the field. This month, we're very pleased to have Abe Wandersman joining us. Abe is a professor in the Department of Psychology at the University of South Carolina and has been the architect around the interactive systems framework, which has had a lot of use and a lot of enthusiasm as a key framework within dissemination and implementation research. Abe and I had a chance to connect a few years ago around sort of mutual interest in terms of developing the science of dissemination and implementation. He actually joined us on an early, I think it was Society for Behavioral Medicine seminar that we did around sustainability. And over the years, we've been incredibly impressed by the work that he's done and thought that this was a great opportunity to hear from him about the ISF. So don't want to take up any more of the time, but we're looking forward not only to hearing from Abe, but then to engaging with everyone on the phone around questions, points for discussion. Again, this is trying to be as interactive as we can, and we look forward to Abe's contribution and then the discussion that will follow. So thanks very much. And Abe, you want to take over the driver's seat?
Absolutely. Thank you, David. I like looking at that picture. That's quite a few years old, and so it helps me look much younger than I think I currently look. I am honored and really have welcomed this invitation. Actually, I've been doing a number of key presentations and talks in April, May, and June. Just did one earlier this week on with the long title of "Evidence-Based Interventions Are Necessary but not sufficient for outcomes: roles for empowerment evaluation and roles for evaluation in an evidence-based intervention world." And so my head was in that for a while, and all I need to do is to turn to this next slide. And Readiness and the War on Cancer is my short version of the title for this presentation. I was impressed, as I'm sure many of you were, and also somewhat depressed by cancer, the emperor of all maladies. And that's when I started to really get into what I would talk about in this presentation. This presentation is very personal for me, or cancer is very personal for me. My mother died of kidney cancer in 1991. My wife, Lois, is a cancer survivor, stage 4 cancer survivor. She was diagnosed in 1999 and is doing terrifically well now. So I know that sometimes it works. And I had the opportunity in 2003 to present this slide and the next two slides in a presentation at Sloan Kettering. And it goes like this. These are the actual content of what I presented. There was a 2015 target date for eliminating suffering and death due to cancer. And it was presented by Dr. von Eschenbach, who at that time was the new NCI director. And he said basically what's on this slide. I believe we are at what I call a strategic inflection in biology, which means we're at a point of unprecedented growth in three key areas related to cancer research: knowledge, technology, and resources. The integration of growth in these three sectors provides an opportunity for exponential progress. To achieve this progress, we must set a clear direction and focus on our efforts into a cohesive strategy. Then went on to say, the goal of eliminating suffering and death due to cancer provides this focus. It does not mean curing cancer, but rather it means that we will eliminate many cancers and control the others so that people can live with, not die from cancer. We can do this by 2015, but we must reach for it. We owe it to cancer patients around the world and their families to meet this challenge. And I said to myself in 2003, well, if my family members and the people I care about and myself can live to 2015, we'll be safe. Well, just last month I had another member of my extended family die from cancer. So I think von Eschenbach had a dream, and I thought of, if you don't have a dream, how are you going to make a dream come true? But we really have to think strategically about how to do a better job, part of which will come from bridging research and practice better. So this is an overview of what I'm going to present today. Some of it's going to be in more detail. Some of it I'm going to skim. You'll have access to all the slides. So when I skim them, if you want to go back and look at them in more detail, please do. I'm going to try to cover a lot in a relatively short period of time. I'm going to talk about bridging research and practice, a framework that I co-developed with colleagues at CDC and elsewhere called the Interactive Systems Framework for Dissemination and Implementation. We're going to drill down and focus in on part of that framework and talk about readiness, organizational readiness to do something new, which of course is very important in implementation and dissemination research. And I'll describe a readiness heuristic. I will then talk about the culture of health, which is a Robert Wood Johnson Foundation major initiative and mission for them, and this year and the coming years. I'll talk about the IHI Institute for Healthcare Improvement's 100 Million Healthier Lives by 2020 initiative, and the Institute for Healthcare Improvement Scale project, which feeds into that 100 Million Healthier Lives and is funded by Robert Wood Johnson Foundation. And I'll try to make some of the connections, particularly using readiness as a key. So bridging research and practice, you know, I assume that's why we're all interested in this terrific series that NCI is putting on. And there are so many examples of gaps between research and practice. I won't go into the details of this one. This one's about electronic medical records. There was an early study that showed that when electronic medical records were used in places like Harvard hospitals, the cost was eventually reduced because there was fewer duplication of tests, and there were some other positive benefits as well, including money saving, et cetera. Then when it got picked up, electronic medical records, and they looked at what actually happened in doctors' offices when doctors had access in practice to electronic medical records, turned out that actually more tests were done, and even more were done with expensive tests. And among the conclusions in the last bullet was the author saying, we still believe that widespread adoption of electronic medical records will improve care and reduce costs. And then I emphasized their words, it is also clear that many office-based physicians will need help in making the transition. It's one of many, many, many examples of a gap between research and practice. I'm sure you all have your favorites. So part of the talk will be on bridging research and practice. I'm going to say something about where do evidence-based practices come from and where do they go. Then talk a little bit about research to practice models, and then go into more detail on this framework called the Interactive Systems Framework for dissemination and implementation. And one of the things that I like to say about the first bullet, where do evidence-based practices come from and where do they go, is it's a little bit like babies. We all know where babies come from, but it's like babies, we don't know what they will look like when they grow up, how they will mature, if they will mature, what happens to them. And that metaphor, roughly speaking, is sort of what happens with a lot of evidence-based interventions and practices. We know where they come from when they're in the carefully developed trials, but what happens to them eventually? Do they get disseminated? Do they have influence? Are they adopted with fidelity and quality? Are they adapted? Are they just forgotten? There are various routes that can happen. So one of the specific things is there are research to practice models. There are models which suggest routes to influence practice. And I will talk about how those models, for the most part, have been necessary but not sufficient, and move into the Interactive Systems Framework, or ISF, which was co-developed with CDC. So this is an example of a research to practice model. It's fairly generic. This particular one comes out of an Institute of Medicine report around mental health disorders. And it has 5 boxes. The first is epidemiology, the incidence and prevalence of a problem. The second is looking for disparities or distinctions where age, sex, race, etc. Some groups do better than others. Does that give us clues about what we might do in terms of intervention? For example, risk and protective factors. Then often there's a move to efficacy trials, randomized control trials that try to reduce risk factors or increase protective factors. And then sometimes we have effectiveness trials which other investigators than the original investigators do the trial with other populations to see how robust the intervention is. If things move from there, or whether or not they move from there, there's the hope that somehow or other these results, once they're published, once they're put on websites or whatever, will get widely used in practice. That's box number 5. So the arrow between box number 4 and box number 5 is the proverbial gap between research and practice. If that was smooth, if there was no gap, we could just happily keep doing what we're doing. But as I've mentioned before, and as everybody on this call knows, there is a gap. And CDC, I initially worked with CDC in the early 2000s, initially with the Division of Violence Prevention, and they said, we know there are many evidence-based programs for child abuse, and there are many evidence-based programs for youth violence prevention, but when we go into the field, that's not what we see. That's not what people are doing. And we could have more of this one-way kind of arrow that I and others think is a sort of trickle-down approach of research to practice, or we could try to think about it in additional ways. And so with colleagues at CDC, we developed this framework, the ISF, Interactive Systems Framework for Dissemination and Implementation, to try to both demystify that gap and also provide some additional ways of trying to reduce the gap. There are 3 interactive systems that we focus on: distilling the information in a lot of fields, including, of course, in cancer. There are hundreds, if not thousands, of articles, whether we're talking about cancer screening or many other aspects. Practitioners are not going to be able to use that kind of scattering of articles throughout the literature, so it would be helpful if there was a synthesis of the findings. And a lot of times those syntheses, like meta-analyses or literature reviews, are not very practical. Are they translated? This is very much what, translational science is about. The top box is the delivery system, and I'm going to start focusing on that in a moment. Those are the federally qualified health centers, the cancer centers, the private practices, hospitals, health systems, et cetera. And I'll go into that in more detail. And then sometimes in between the information at the bottom and the delivery systems at the top are support systems that provide training and technical assistance to try to help get the useful knowledge from the bottom into the delivery system at the top. All right, so in the delivery system, we have general capacity. General capacity are these kinds of characteristics, and one of the ways I like to describe this is you have to be a good host organization. You have to be a healthy host organization to put an evidence-based intervention into practice. If your organization is dysfunctional, falling apart, unstable, bad leadership, it's not likely to put an intervention into place very well, even if it's gold standard intervention. So this looks at and tries to talk about what's in the literature about general capacities. What's the organizational culture like? What's the climate like of the organization? Is it a welcoming climate? People like working there? Is it used to innovation, or do they just like to do things in the same way? That's the only thing they're comfortable with. How good are they at using resources? Obviously, leadership is key, as many researchers have pointed out. What's the structure like in terms of decision-making and communication channels? And what's the capacity of the staff, the number of people, their skills, their abilities, et cetera? A lot of these variables are in a kind of normal curve. There are organizations with really top-notch leaders, many organizations that are kind of in the middle, and then some, of course, at the lower end with really poor leadership. And that's clearly going to affect an organization's general capacity. And we propose that a normal curve or something like it is true in many organizations. We're going to have a lot of variability in general capacity. We're going to have a lot of variability in how healthy the organizations are in terms of how they function and whether they can put an intervention into place. There's also another kind of capacity that we talk about, and that's innovation-specific capacity. And we define innovation as a program, practice, or policy that's new to an organization. It may have been around for a while, but it's new to this particular place. And it's going to require various kinds of things, specific knowledge, skills, and abilities about how to do this intervention. Let's say it's a particular way to do cancer screening, colorectal screening, or some other version of screening, or some other kind of intervention. Does this particular innovation have a champion, somebody who's in a good key position that's really a booster for it, that keeps it on the radar, that says this is important? Are there specific implementation supports to the staff on how to do this? Are there prompts? Are there somebody to answer the questions that they might have about how to actually carry it out? And then interorganizational relationships in relation to the particular innovation. Some innovations require connections with other organizations. At the least, it might require referrals, and in other cases, it might require team approach or interdisciplinary teams that might be outside of the organization. One of the things we added to the original ISF is motivation. In the South, we have a phrase called being hit upside the head. And one of my previous graduate students, and now currently recent PhD, Jonathan Scatia, figuratively, not literally, hit me upside the head and said, you know, capacity is important, but we really need to think about motivation. And it's not like I never thought about motivation before, but we really had to bring it in specifically and think about what the literature said about motivation. And that's something that we've done more recently. We certainly didn't develop it, the idea, and you can see by the references that there have been quite a few people thinking about motivation before. What's the relative advantage of this new program or policy to what I've already been doing? Why should I do this? What does it offer me? How compatible is this new thing to what we already do? Does it fit with our culture? Does it fit with the way we do things? how complicated is this new thing? The more complicated, the less motivated. Trialability is, can we try this in a small pilot way, or do we have to change our whole organization to really do this new thing? If it's easier to just try it, it's more likely to get the motivation. How observable can we see some short-term gains that might reinforce us for doing this? And last but not least is priority. Is this something that's mandated for accreditation or elsewhere? Priority plays a big role in motivation. So we came up with a heuristic that said that all three of these things are important. It said readiness for I. The I stands for innovation. Readiness to do a particular innovation. Whoops. Sorry. This actually often comes with sound, but something's happened here. What we're saying is that the three components, motivation, capacity general, and capacity innovation specific, are multiplicative. You can have all the motivation in the world, but if you're missing one of the capacities, you're not ready. Or you can have all the capacities in the world, both general and innovation specific, but you're not motivated. Other things are more important. We see this all the time. We see it in ourselves. Things that are more important crowd out the things we have capacity for. We do the things that have the most squeak in the wheel. So we've come up with a heuristic, MC squared. You may have heard of that before. It's an easy way of thinking about readiness. Readiness is a function of motivation times capacity general times capacity innovation specific. So one of the things that is going to be real important in dissemination and implementation is, will there be support to help build either the capacities or the motivation of our practice organizations? And support systems also can be looked at in terms of their general capacity, their motivation, and their innovation-specific capacity. So back to the ISF. As I mentioned, this was originally developed with CDC, with the Division of Violence Prevention. Quite a few other branches and units at CDC have been using the ISF. It's gotten a lot of use by the Division of Reproductive Health in their work on teen pregnancy prevention and STD prevention. In terms of synthesis and translation, there are hundreds and hundreds of articles related to adolescent STD prevention and teen pregnancy prevention. There are over 31 evidence-based interventions. So if you're a practitioner, you need to figure out, what do we know and how do we use it? And that's where synthesis and translation comes in. And the Division of Reproductive Health found this framework a useful diagnostic to see what they were providing to the top box, the delivery system. Is the information there? What kind of organizations and national providers might be providing training and technical assistance to the delivery system? So they use this, and without going into any detail, wanted to promote a process called Getting to Outcomes as a way of thinking about which interventions a particular community or organization should use, how they would plan it, how they would implement it, how they would evaluate whether what they were doing or not. That's a whole other talk, that Getting to Outcomes talk. But the need for a process that local organizations could use, boys and girls clubs, after-school programs, school systems, was an innovation that they wanted to bring in to use evidence-based interventions in a systematic way. This ISF figure was developed and published in, well, it was published in 2008, and there have been some innovations since then, some additions since then. So we added motivation, which you can see in the oval in the middle of the top box, as well as the middle box. And we clearly said this framework is not only about building capacity. People really want outcomes. Well, that was always the reason we were doing this. But what we did in more recent versions of the framework is make that very explicit. So implementation, the yellow arrow of implementation, is very explicit, and that's where implementation science comes in, and that it leads to outcomes. That's the prize we're looking for. So in the framework, there's implementation science, dissemination science, translational science. Now I want to drill down and talk about readiness. There are many things I could talk about in terms of the ISF. I want to talk a little bit more about readiness. Organizational readiness is important if we want to help organizations put an innovation into place in a way that has quality and is more likely to lead to quality implementation and good outcomes. We also think that readiness is not a one-time thing. Are you ready to start? It's really dynamic. You can be ready to start, but things can happen. Are you ready at all the stages or phases involved in implementing something all the way through to sustainability? So there's a lot of interest in building readiness. What are some strategies for building readiness? And there are these well-known strategies. There's providing tools, but we also know that tools in general, like a book, is not sufficient. Right now, if we're thinking about teaching somebody to drive, picking up a book from the Department of Motor Vehicles, very few people are going to learn to drive from doing that, but a lot of times when we give out manuals, we expect people are just going to do it. Sometimes tools are supplemented by training. Training is done in groups. One size fits all. Not everybody is getting what they need. And in fact, the literature evaluating training shows there's very little transfer of training into utilization if it stops at training. So we move into technical assistance or coaching, on-the-job training, or very immediate to the immediate needs that a technical assistant recipient has, in this case a student driver. But last but not least, we don't stop at technical assistance when we talk about driving. We actually have quality assurance, quality improvement. There's an actual test to see if they really know how to do all the things necessary to drive well. So we've developed this logic model to connect the middle box, the support system, with the top box, the delivery system. And basically it says to achieve certain desired outcomes, we need to look at the initial readiness, and we know that initial readiness varies on general capacity, innovation-specific capacity, or motivation. And we need to meet people where they're at. We need to meet organizations where they're at. We know they're going to vary. Some organizations need more motivation, some need more general capacity, some need more innovation-specific capacity. And by using tools, training, technical assistance, quality assurance, and quality improvement, those strategies of support will hopefully get us to accomplish the desired outcome. We also note that relationships are key, that if there's no trust or little trust, particularly when we get to technical assistance and quality assurance, there are going to be real problems in this kind of a system. One of the things we have been advocating and proposing is that there be an evidence-based approach to doing tools, training, technical assistance, quality assurance, with the idea being if it's important to do evidence-based programs to get outcomes, we think that tools, training, TA, and quality assurance, quality improvement should also be done in evidence-based ways. Training, not all trainings are of equal quality, not all technical assistance is of equal quality. How do we actually develop evidence bases on support strategies? So now I'm digging a little deeper into readiness. What evidence is there that factors that I've described about readiness actually can be changed by doing support? And do support system activities actually help build the readiness and lead to better outcomes? And we've done a recent review that we are hoping to publish in the near future that of the literature. It's a very systematic research synthesis that provides support for this. So I want to quickly move into some emerging uses of the readiness heuristic. One is by the Cancer Prevention and Control Research Network. I'm working with the one based in South Carolina, and I'll quickly describe something that we're doing there with readiness. and then quickly mention something about its involvement in 100 million healthier lives and scale. If you hear me rushing, I am. I want to just touch on these next few, and as I said, you'll have access to the slides if you want to look at them in more detail or ask about them in the Q&A. So in the CPCRN, there's a signature project that is just starting with FQHCs to increase colorectal screening, and we're going to be using the Readiness heuristic, working with the FQHCs to look at their potential readiness or how to build their potential readiness to do the screenings. One of the areas I've been interested in for a long time and still am is around healthy community initiatives. This particular first bullet is from YMCAs and YCWAs across the country have gotten involved in healthy community initiatives. I think you all know what they're like. They're trying to promote healthy lifestyles through various kinds of policy change and physical surrounding change. CDC has obviously been involved in many healthy community initiatives. Let's Move is an RWJ. There are many, many of these kinds of initiatives going on. One that I'm involved in now is this 100 Million Healthier Lives, which was launched by the Institute for Healthcare Improvement as a major initiative, particularly around population health, that started in the last year in 2014. On January 15th, 2015, a project called SCALE was funded by RWJ to IHI, and I'm leading the formative evaluation of SCALE. I'm just going to briefly describe that and how that relates to readiness. So RWJ is major mission for them is promoting a culture of health. They are a real stimulus and catalyst around the country for health, and it's exciting to me that they're not only talking about an absence of illness, but really on a holistic approach to health. So they have funded SCALE, which fits into the 100 Million Healthier Lives initiative. And the concept, very briefly, is that there have been successful healthy community initiatives around problems such as homelessness, child obesity, violence, et cetera. What can other communities learn from the successful communities? So a major way of working in the SCALE initiative will be healthy community spread, inter-community collaboration, inter-community mentoring. And so that's going to be a major value added that we're going to be looking at in the SCALE initiative. The first wave is what we just started, January 15th. It's the first column. 186 communities applied. There are 20 pacesetter communities and 4 mentoring communities. In order to be a pacesetter, we have 20 months to be in the SCALE initiative. We couldn't start from scratch. We needed a certain amount of readiness. And we used the R equals MC squared in the application, in the written application, and then the 50-some finalists all had an interview, again grounded in large part around those 3 components: motivation, general capacity, innovation, specific capacity, with the idea that they needed a certain amount of readiness to be able to benefit in the 20-month period from what was going to be offered. So there's peer-to-peer learning, there's a leadership academy, there's electronic platforms, there's the context of the 100 Million Healthier Lives initiative also being supportive. There's a lot of things going on, and there's more about it on the IHI website. We're doing a formative evaluation to look at what accelerates and inhibits progress, and I know you can't see this, but this is what the SCALE trajectory looks like from the application process, the onboarding process, the leadership academy, the peer-to-peer and community of practice mentoring, the mentoring by organizations that have been successful in working with large-scale initiatives and getting amazing results. One of the organizations has helped 100,000 homeless people find homes. I find that really impressive. And then it moves into the outcomes of this first phase of scale, and also what can be learned by this that can translate to many more communities so that we have more inter-community spread. So as I mentioned before, we use these three components, motivation, general capacity, innovation, specific capacity, in the application process, and we're going to be looking at readiness all the way through. Because readiness is dynamic. Just because you were ready at the beginning doesn't mean you're ready 6 months later and 18 months later to carry on the various kinds of tasks and activities. So we see readiness as dynamic. Coming back to the ISF, you may remember this figure, the 3 boxes of the ISF. And what we're doing in this figure without any detail is showing that we're going to be using the ISF to help us map out how to do the work in the SCALE initiative. So it is important to have a dream. We need to have ways of making a dream come true. And I'm going to just quickly, because I've gone over a lot of stuff, quickly review what I've been talking about, and then I'll be happy to entertain questions and comments. As I said before, sorry to dizzy you this way. If you're having flashbacks, we all are. Readiness in the war on cancer. This is a very important for me in a personal way as well as in a research way. What are we going to do? How are we going to bridge research and practice? I talked about the ISF, the Interactive Systems Framework, the readiness heuristic, R equals MC squared, the importance of a culture of health and how we might actually get there. I think these will look familiar to you. These are the components of R equals MC squared, general capacity, innovation, specific capacity, and motivation, the R equals MC squared heuristic, the need for support to actually help organizations learn to be more ready, the idea of tools, training, technical assistance, quality assurance, that there's a logic model that connects the support system with the delivery system. This is an example of that. The use of readiness and the CPCRN. This is really frontier work for us. We're just starting to develop this, the measurements for this, and starting these projects off. Use in healthy community initiatives. The connection between the SCALE project and the ISF. And trying to make a dream come true that obviously we won't solve the cancer issue by 2015, but hopefully we'll make a huge amount of progress in the next 5 years. In 2003, there wasn't much of an implementation science. There wasn't that much interest in translation compared to where we are today. So I have hopes. So I'm ready for questions, comments, et cetera.
Abe, thank you so much. And we will, with that, open it up for questions. Just a quick reminder to everyone, there are 2 ways you can submit your questions. You can press *1 to ask your questions on the phone live, or you can use the Q&A feature at the top of your screen for those of you on live meeting. Just type your question to the provided field and hit Ask. And I will now turn it over to David.
Great. Thanks very much. And again, echoing Sarah's appreciation for Abe's presentation. I do see already we have one question that's come in, a clarifying question from Jill Locke. Abe, can you talk a little bit more about how motivation might be different from buy-in, same or different from buy-in?
Sure. I think buy-in is a general term. So what does that mean? I think motivation would be a way of concretizing some of the elements that would lead to buy-in, like relative advantage. That would certainly help buy-in if the people involved think this will be a great advantage over what we currently do versus, and this happens a lot, what we're doing right now is probably just as good as what you're offering. Why should I change? Why should I do all this new stuff when what we're doing is pretty good already? So I think if you look at these features, among others, they would help us understand what buy-in means. At least that's my first reaction, and if that doesn't hit the nail on the head or come close, I'd certainly welcome thinking about it differently. If the person who asked that question wants to respond to my initial reaction, I'd be happy to hear it.
Okay. Great. Yeah, so certainly the phone lines can be open if Jill wants to follow up. Maybe in the meantime, we'll take another question from Nadia, which says, could you tell us a bit more about how the three systems in the ISF model influence each other? What mechanisms and tools have been shown to be effective to help the three systems communicate better?
Okay. Let me just find that for a moment. So when we first came up with the ISF, which was published in 2008, we always had the arrows connecting the systems in there, but we thought the real action was those arrows, that the systems in and of themselves, were obviously important, but the real work needed to happen in connecting those systems. So so if you see, I don't know if you see my cursor. Do you all see my cursor?
Oh, I don't think we can. Okay.
There's an arrow that says EPSIS that connects the, yeah, thank you. Beautiful. That's a connection. How does the support system connect with the delivery system? And that's where EPSIS stands for Evidence-Based System for Innovation Support, and that's where this logic model, and I apologize for the lettering not being exactly as clean as it should be. This logic model is an example of that connection, okay? This is a way that training and TA centers can connect with the delivery system. And what they should be doing from a strategic sense is not giving the same kind of technical assistance to all parties. They should be basing it on the general capacity of a particular delivery system. Some delivery systems may be stronger in some areas and weaker in other areas. The TA should take that into account and really focus in on that so that they can more effectively and efficiently use it. I'm trying to remember. Can you repeat Nadia's question? I think I've addressed a lot of it.
Yeah, the first part, just adding, the second part was around mechanisms and tools that have been shown to be effective to help the different systems communicate better.
So one of the things that is crucially important is relationships. So one of my grad students who's graduating, Jason Katz, graduating next week, has done a research synthesis of the literature on technical assistance, looking at issues around relationships, which I think are really key and often get ignored, at least in they're not given as much attention as they need to get. Relationships are a necessary part of effective technical assistance and even training. As I mentioned before, without the trust, it's not going to go very far. In terms of tools, there are various tools. I've developed some, as have many others. We have used this getting to outcomes process, which is a whole other talk. It's a 10-step approach to results-based approach to accountability, or a results approach to accountability. And with that, we do have manuals, which we keep trying to evolve and make better. We do have, trainings that we do. We have been looking at technical assistance and working on proactive technical assistance. Much of the technical assistance that's been provided has been reactive and responsive. But lots of times the recipient doesn't know what they don't know. And proactive technical assistance suggests that there is something that the TA provider knows is going to be coming up and wants to help prepare the TA recipient, the delivery system, to do. So there really are actually quite a few kinds of tools and mechanisms and channels, but a lot of it is going beyond the manuals and the websites. Manuals and websites rarely are sufficient to get quality utilization, quality implementation.
Great, thanks. So we do have another question. Oh, sorry. I think it sounds like we might have one live.
Yes, we do have a comment from Jill Locke. Your line is open.
Oh, great.
Oh, Abe, I just want to say thank you so much. That was very clear and helped me think about motivation and buy-in in different ways. So thank you for that.
You're welcome.
Great, thanks, Jill. So the next question comes from Steve Kaplan. Could you talk about assessing organizational readiness a bit more? How do you assess it with surveys, for example? Do you survey a random sample, the leadership, or key individuals in the organizational structure?
Well, obviously, it will vary with various kinds of mechanisms and incentives. And it also depends on the stage we're talking about. Initially, in terms of adoption, we clearly need to get the key leaders involved and look at their readiness. Once you move beyond the initial adoption into are they really ready to implement, it's really important to survey the people who are going to be doing the work. Moving down to mid-level and hands-on folks, because those are the people who really need to be ready to put something into practice. So it's got, as I mentioned earlier, readiness is dynamic, and some people can be ready. The leaders at the top can be ready, but that certainly doesn't mean that the staff is ready because they need the training, they need the motivation, et cetera. So my answer, Steve, is as you might expect, we need them all sooner or later.
Great, thanks. And actually, it looks like a related question that just came in, which is, could you provide some examples on assessing motivation at a system level? Is it an aggregated approach? How does the framework account for variability within a system?
I'm going to try to take that. Oh, thank you. I'm going to try to take that in two parts. And say the first part again, David, please.
Sure. Could you provide some examples on assessing motivation at a system level? Is it an aggregated approach?
So motivation for us is the newest part of what we've been doing. We've been doing the capacity stuff for quite a few years now. We are just starting on the motivational part. So I'll tell you what we're starting to do, and then we welcome all kinds of ideas about what would be better. Yes, right now we're talking about aggregating motivation from the key people that we'll be getting the information from. Well, that's my short answer. What was the second part of that?
Yeah, so the second part I think goes along with it, which is this question of, is there a way that the framework accounts for variability that you would detect within a system? So is there heterogeneity of response, and how does the framework take that into account?
Well, what comes to mind for me is this idea of the normal curve. I mean, I'm expecting that when some new intervention is introduced, let's say we're trying to do a new innovation with 10 FQHCs, we're likely to see variability in the relative advantage in each of those 10. There's no reason to think that they all think that this great new thing is the best thing since sliced bread. Some of them are already doing, for example, a kind of cancer screening, and others it may be brand new, and so the relevant advantage is there's no inhibition to doing this because they have something they're already doing in its place. So it's very much that kind of thinking that these are variables, and that's what makes this, I think, potentially both powerful and hard. Is we're not talking about a general readiness. The formula, the heuristic is readiness for a particular intervention or innovation. So it's very specific. How ready is the organization to do this particular innovation in terms of their motivation for this particular innovation and in terms of their innovation-specific capacity? What are the capacities needed to do that particular innovation? And some screening approaches, for example, might be much more complicated than others. And we think it will be more powerful in terms of prediction to focus in on those in that kind of a specific way.
Thanks very much. And I would assume complicating that challenge might be if an intervention is located at potentially a lower level within an organization, you might have variation in terms of, say, individual providers and their readiness to implement a particular intervention, and trying to take into account these multiple levels, I would assume, would just add both to that complexity, but really, the challenge of getting the strategy right.
Well, absolutely, David. I mean, it goes back to what I started out with, that there is a gap between research and practice, and there are many reasons why. It's not that easy to bring something new into a system. And, what we've mentioned here so far is just the top of the iceberg. There are lots of things. And that's why this frontier is so important and so interesting and so challenging. Is what are the good levers, and that's what we're going to be looking for. Where we're going to get the biggest bang for our buck in terms of motivation. What are the kinds of things that would be most influential? My guess, often, let's say, if we're talking about motivation, is something is a priority, if something is required. That's usually got a pretty big lever. Then when you're looking for people to adopt something just because it sounds, it's a good thing to do. So I think I am a psychologist, and I think a lot of this involves psychology. What do people like? What does it get for them to change their behavior?
Wonderful. And with that, and to be cognizant of time, I want to take a moment to say a big thank you to both David and Abe for their time today. And as a quick note, your feedback is important to us, and we encourage you to complete our online evaluation, a link to which will be sent out to you shortly in an email. Finally, as mentioned, we'd like to continue this discussion from the webinar online at researchtoreality.cancer.gov, where you can engage with the speakers and other participants through discussion posts and forums.